Good afternoon, everyone. It gives me immense pleasure to be part of this wonderful symposium. At the outset, I would like to thank Yashoda Hospitals and Dr. Rashikar for inviting me for this wonderful meeting. So I'll be talking on newer techniques in AF ablation since there has been a lot of advances in the recent past. So as we all know, atrial fibrillation is the most common tachyarrhythmia, which accounts for almost one-third of all hospitalizations for cardiac arrhythmias. It is strongly associated with the increased risk of stroke and heart failure. So this ECG must be familiar to all of you. So you can see the rapid fibrillatory waves with the irregular ventricular response. So these are some of the mortalities and morbidities associated with atrial fibrillation. So there is increased risk of death in patients with AF compared to patients without AF. There is almost 5-fold increased risk of stroke, 10 to 40% increased risk of hospitalization, and there is also impaired quality of life because of irregular cardiac rhythm. And then patients are also at risk of LV systolic dysfunction and heart failure, and eventually with chronic AF, there can be cognitive decline and vascular dementia. So with the aging of the population around the globe, the prevalence of AF is only going to increase. So I will not be wrong if I call that AF is going to be the next pandemic. Coming to the clinical classification of AF, so based on the clinical patterns, AF is classified into paroxysmal, persistent, long-standing persistent, and permanent AF. So paroxysmal AF means short-lasting episodes of AF that terminate spontaneously, and arbitrarily we say that any AF that lasts or that spontaneously reverts within 7 days, we classify that as paroxysmal AF. So initial stages of AF, initial stage in the natural history of AF, most AF episodes are paroxysmal. They tend to terminate spontaneously. Over a period of time, paroxysmal AF can become persistent. So any AF that lasts for more than 7 days and that requires some form of intervention, either cardioversion or antiarrhythmic medications for its termination, so we label that as persistent AF. And any persistent AF that lasts beyond 1 year, we call that as long-standing persistent AF. And AF that cannot be cardioverted, or where the clinician and the patient accept the presence of AF and then pursue only rate control strategy rather than rhythm control strategy. So that is also a form of permanent AF. So as you can see here, earlier stage you have paroxysmal AF and early persistent AF, and as the AF becomes more and more chronic, you have long-standing persistent AF and eventually permanent AF. So a patient of AF presenting with paroxysmal AF has almost 30 to 50% risk of progressing to persistent AF over a period of 10 to 12 years. So it is very important that we treat AF at a very early stage before any structural changes happen in the left atrium. That is structural remodeling and fibrosis that tends to develop with chronic AF. So again, this is the same thing. AF begets AF. So AF that starts as paroxysmal AF causes structural remodeling in the left atrium, and then which eventually causes persistent and permanent AF. So these are some of the consequences of AF progression: decreased quality of life, increased risk of stroke and heart failure, increased risk of hospitalization, and eventually increased risk of mortality. So briefly about pathophysiology AF, because this is very important to understand the treatment approaches. So paroxysmal AF generally is driven by certain ectopic foci which fire at a very rapid rate. And then we know that from certain seminal studies, so the pulmonary veins act as one of the most important ectopic drivers or triggers of atrial fibrillation. And then there are other non-pulmonary vein sources also which are relatively rare, such as the ligament of Marshall, the SVC, the coronary sinus, and others. And in patients with persistent AF, so you have got triggers coming from the pulmonary veins and from other sources, but then they also tend to have significant amount of atrial fibrosis. So both trigger as well as substrate is involved in persistent AF. So a trigger will initiate AF, which is then sustained or which is made persistent by the underlying substrate. So this was the landmark paper by Hassegare group from Bordeaux, France, where they showed that pulmonary veins were the primary triggers for patients with paroxysmal AF. And then they showed that ablating inside the pulmonary vein could cure AF in these patients. So currently speaking, we have got 3 different modalities for atrial fibrillation. One is the conventional radiofrequency ablation, which is high frequency alternating current. Then you have got cryoablation, where we use liquid nitrogen at a very low temperature to freeze the myocardium. And then finally, the new kid on the block is the pulse field ablation, where we use high voltage electric fields to cause irreversible pores in the cell membrane of the myocardium and thereby cause irreversible injury. So the most important endpoint in AF ablation is achieving durable pulmonary isolation without leaving any gaps. So if you can isolate the pulmonary veins from the left atrium, then whatever firing or ectopic firing that happens in the pulmonary veins cannot enter the left atrium and cause AF. So that is the goal of AF ablation. So coming to RF ablation, so it is performed by point ablation. So we don't ablate inside the pulmonary veins anymore. We don't ablate near the pulmonary vein ostia also because of the risk of pulmonary vein stenosis. Rather, we ablate in the antrum of the pulmonary vein. And circumferentially by point ablation, we achieve pulmonary vein isolation. So nowadays, traditionally we were using low power and long duration ablation or medium power, medium duration ablation. However, in the last few years or so, we use high power short duration ablation. So we use very high volt, this is paradoxical. When we use high power, we think that there can be more damage, but then the damage is significantly less with high power and short duration ablation. And then whenever we are using RF ablation, we can do additional linear ablation for treating atrial flutters as well.